Hi everyone, welcome to our second episode of the FIERcast. My name is Emeline and I am the current Master Fellow of the program. We have here also Dr. Adriano, Dr. Freddy, and Dr. Lucas, who are fellows as well. In today's episode, we are so happy to have here Dr. Parolini. Dr. Parolini is a great retina surgeon from Italy, and she has been teaching and helping people around the world for a while. So we also have Dr. Flávio Rezende here. He will share with us his knowledge and experience. Thank you, Dr. Parolini. Welcome. To start, could you share with us a little about why did you decide to become a retina surgeon?
First, let me say something. Hi, Barbara. My name is Flavio. I would just like to give a short introduction. Reason why we invited Dr. Parolini to be the first international guest of our FIER videocast. Barbara has been contributing to the surgical field of retina for the past, I don't know how many decades. And it's been a surgeon. She doesn't know that it's been a surgeon that I've been looking up to her for a long time, and I was thrilled that she accepted our invitation for the podcast. Um, the FIER program, it's something that I'm originally based nowadays in Montreal, Canada, but I'm originally from Brazil, born and raised in Brazil. And this is something that it's a program that we created since last year. And we've been trying to raise the level of the high-end surgical retina in some areas in Brazil. And these are my first what we call master fellows of the program. And so it's an unbelievable, they don't understand how lucky they are to be interviewing Barbara. So thank you very much, Barbara, for accepting our invitation.
Thank you so much. Thank you. It's an honor to be here, and I'm so pleased about this invitation. And I'm grateful, very grateful. Thank you. I live in Italy. I'm in North Italy. My hometown is Verona, which is in Northeast Italy. And I went to medical school there. I always decide at the very last moment in each program of what I want to do in my life, because the problem is that I like everything. I like knowledge. I'm always very curious to learn everything that I possibly can. So before going to medical school, I was in a classic in Italy. We call it Liceo Classico. It is a high school where we study history, Latin, and Greek, but also we were studying scientific topics like physics. Anyway, I was about to finish my high school and I met a young doctor, and he was telling me what he was doing in his life, his dreams, his experiences in Italy and abroad. He was doing some volunteer work. Anyway, I was so fascinated by that interview. He's been a key factor that changed my choice. So I went to medical school, and when I finished, even there in medical school, I liked everything. I didn't know what I wanted to do. I was actually following a program in rheumatology. I had to become a rheumatologist, but at that time of in the last year of medical school, as you probably have done, we had to make some experience in each different clinic in the hospital. So when I arrived in the ophthalmology clinic, I was assigned to a female doctor. She was so passionate, and she took me to the OR and she asked me to look through the microscope. It was a cataract surgery, and I was so amazed to find out what I was looking at through the microscope. And in those few days, I saw that I could cure any age, from pediatric to old age. I could do medical, I could do surgery, I could do technology. I was very passionate about technology. And so that was it. It was just, I was in love. So basically, every choice of mine is a passionate choice that I make at the last minute. Like I find the key factor to change abruptly my life. And I've been so happy. I never regretted any of this choice. So when at the end of my medical school, 6 years it is the program in Verona, and I think it's almost the same everywhere. I went to United States because I was proposed to go to have a basic science fellowship at UCSF, so in San Francisco, California, with Professor Marco Zarbi. He was focusing his research in RPE transplantation. And so I did RPE transplantation in vitro, in vivo, in animals. I did a lot of scanning and transmission electron microscopy, trying to grow RPE cells with different growth factors, things like that. And then I went back to Italy 1.5 years later to start my residency in ophthalmology. And in 1994, and I got married in 1995, by the way. So profession and personal life, of course, runs all along.
Very
So residency is 4 years in Italy, but 3 years later, I went back to United States to do something completely different. I have been asked by an engineer, Dr. Eugene Gordon, to work for his company, the MedJet company. They were building instruments based on the water jet technology. And I was leading the research and studies to obtain the FDA approval for the instrument. But they were mainly dedicated to anterior segment and refractive surgery to cut the cornea, basically. So at that time, I was deviated to anterior segment and refractive surgery field. It's been very interesting. But they taught me how to deal with the engineers, with the R&D department. And I learned how to think as they think. And I think it's been very useful in the more recent years when I worked with the Macular Buckle project. So I had this experience, but my love was always retina. When I went back to Italy to finish the residency, I actually opened the first refractive surgery center in Northeast Italy. I was doing the key operator with the laser for my colleagues. So I was a refractive surgeon at that time, but I was thinking about retina. So I went to a hospital to start surgery, retina surgery. And I was doing both things simultaneously. So that's how I started. But and in 2005, I went. Grazia Pertile asked me to work with her in her hospital. I increased a lot my surgical experience in every subfield, like cornea, glaucoma, complex cases, trauma, subretinal surgery. And actually, I gave a reason to my first research in RPE transplantation because I started to do choroid and RPE transplants in my patient. It's been wonderful. I was, connecting the dots. That's it.
Excellent.
So you didn't have a specific vitreoretinal surgery fellowship, right? So you were.
We don't have.
Training,
Yes. I'm very, very self-made. So I was observing my colleagues, and I learned one thing from one, another thing from the other,
amazing.
and then I try to build my own
Genius.
experience. That's it.
This is a great inspiration.
Yeah.
Well, it is possible. Yes, I can say that it is possible to do so. Yes. What I always chose to do, and I think it's been important, if I can offer some advice. I've been working mainly out of the university in hospitals, a community hospital or private hospitals, but I wanted to work as if I was in the university. So basically collecting every possible data of everything I was doing and trying to learn from my data, my mistakes, my good results, and to publish. So if you have a systematic way of working like this, you always control what you're doing and you grow. You grow a lot, no matter where you are working. So I think this is a chance that anyone can do. Just have your own system, but be very precise, very systematic,
Wow.
and very honest.
Basically, what
with
you're
you
saying is that,
collect.
right. Basically, what you're saying is that we're the ones who put our own barriers in front of us, right?
True. Exactly.
Yeah.
It doesn't matter where you work. It means you confront with yourself. So you have to, have a system and be very honest, but collect every data. Because when I hear in meetings many colleagues saying, this thing goes like this thing goes like that, but how much of your data are you really looking at, and how much are you relying on your memory, your feeling when you give sentences? We should try and rely on what we really observe, because I learn on myself that when I look at my data of few years back, I don't remember exactly what I was doing. So if I had to doubt myself, I think this happens to anyone. We need to write down, archive the images, the data, and be very, solid and sure when we give sentences on what to do.
Excellent.
Okay. So there's two things that I'm hearing here. One is that make no excuses for you guys, listening to us. There's nothing that it is a barrier. It depends on how far you want to go. This is number one lesson.
Yes.
And the second one is that at key points in Dr. Parolini's life, she had mentors, even though sometimes the mentors, they don't even know that they were being an influencer on her. But that's what ended up, guiding her. She mentioned two giants in the field, Dr. Zarbin, and I know him personally as well. Dr. Pertillo, these are two,
Yes.
And probably they didn't know that Barbara was going to become what she became,
True.
so it's
True.
very important, not to give up, make target, and you go regardless where you are, and try to find mentors that, can help you, guide you along the way.
Yes, I have two more things to say about that. At one point of my life, it was 1998, sorry, at the end of 2000, I was not so happy with my retina surgery results. And so I decided to travel. And to ask different colleagues to watch them work in their OR. So I went to visit many colleagues in Italy and abroad, because I thought that just watching unedited work and hearing their real life experience could be useful. And actually, it was extremely useful. I could learn what I liked and also what I didn't want to do. So I encourage other colleagues to do the same. The second point, and allow me to say that because I'm a female and I'm very often asked how it was being a female in a man world like vitreoretinal surgery.
Right.
I can tell you that I never felt that I never felt that as awkward. It was very natural. I want to tell all my female colleagues that if I did, anyone can do. Just be a very honest scientist. So rely on what you can do, rely on your thoughts and your experience. You can do everything, and you can also do it in parallel with a very successful personal life. I have a husband and two wonderful daughters, and just find the perfect husband. It must be very very understanding and very supportive. It has to, believe in your career. That's the only key factor. But anyway, you can do everything. So just don't say I'm a woman. There are, fights against the discrepancies between the female and male career. I don't believe in that. I believe in being a good scientist and do whatever you want to do. You can reach any achievement as long as you really want it.
Excellent.
Yeah, so that's amazing that you mentioned this, because the FIRE program is, so all the fellows, that's why we call them the master fellows. So they already done their fellowship in Brazil, and then they were selected to be part of the program. So they come here to Montreal, they watch us operating here, and then I go to Brazil and I
Right.
tutor them on their own OR. They are operating, and then I'm making adjustments for each one of them in their own
Wonderful.
place. Yeah. So
Environment. Yeah.
it's amazing that you mentioned this, because that's exactly what the FIRE program is about.
Wonderful.
Yeah, I agree with your advice that watching experienced surgeons, you learn a lot, even for 1, 2, 3 days. And something that I noticed, that you see things that you will not do, and maybe they're so important as the things you will do, because you see different things and say, oh, that's not for me, I prefer doing that way. And are pretty nice advices you did.
Barbara, one of the main reasons of the program is to teach us in very difficult, very tough cases. And I'd like to ask you, what's your mindset in very complex cases? And you're a very experienced surgeon in these cases, like RPE transplant and macular buckle. And how did you get there?
So I always like the challenges, telling the truth. I always went for the most difficult thing because, we have to leave a trace in life. We have to leave something of us, and we need to, be part of this chain that improves the world and the things around us. That's one in my mind, and I think it should be in anyone. So when I entered the ophthalmology field, the vitreoretinal field, I observed these very two big gaps and unmet needs. So the expectations of patients with maculopathy, and the patients with high myopia and myopic traction maculopathy. Basically, they were always the patient that entered your consultation room, and you were already ready to tell them, I'm sorry, you have maculopathy. I'm sorry, you have a subretinal hemorrhage. There's nothing that can be done. Or I'm sorry, you have high myopia. Your destiny is to become blind. At least this is what was in everyone's mind. And I could just not accept that. So since I had done the RPE transplantation in Vitreous, I thought we could do it. And when I started to work with Grazia Pertile, she had already done macular translocation. It was not the same thing, but the rationale was the same. Basically, she was rotating the retina on healthy RPE. And we decided together, Grazia and I, to start rotating the RPE without rotating the retina. The rationale, the aim was exactly the same. So, and I still remember in 2007, we planned at a table how to do the surgery based on her experience of macular translocation and what had been already written on RPE transplantation. RPE transplantation was already done, but the colleagues before us, basically they were not detaching the retina at the periphery. They were detaching at the posterior poles, and they were cutting a full thickness patch of retina and choroid, elevating the posterior macula, removing the CNV, and inserting the patch of choroid harvested in that way. But the PVR rate was 40%, something like that. So it was not acceptable. So Grazia and I said, why don't we combine the idea of translocating the RPE, but using the technique that we use in macular translocation? So let's cut the periphery of the retina, discover the subretinal space, and do everything we have to do, and then reattach the retina. So we did. And I still remember the first time we cut through the choroid. We were so afraid of what could happen, how much it will bleed. Should we use what? The electric cautery that we use for dermatology? Anyway, it was easier than we thought, fortunately. And we did it. I suggested to use PFCL. So if you can imagine, the first time we didn't know what could PFCL do on the RPE because it had not been done before. So there was a lot of first time there. Anyway, it's been an amazing experience. And we found out not only that it was feasible, but in some patients, it made a huge difference in their vision because we could save some vision for a long-term time. So it was nice. What Grazia did was, a great contribution with her experience in the previous surgery, and together we combined, we built the new technique. As far as myopia is my biggest love, because I was so sad to see that when I had a detachment of the macula in a staphyloma, I was doing the traditional surgery and the outcome was very, very disappointing. I think everyone had the same experience in life. So I decided to try to buckle the retina because, I thought that it made total sense to shorten the eye because every problem in high myopia was due to the elongation and to the posterior staphyloma. So in 2007, I started to buckle the retina with everything I could, like silicone band that we use for the retina detachment surgery. I even used a pediatric Foley balloon. I injected viscoelastic in the balloon. I placed it under the macula, but it was a very awkward surgery. I had to pass through the inferior oblique muscle from 6 o'clock to 12 o'clock. It was working, but I said, if it is too difficult, nobody will do. So I was working at the time in a big hospital, and I thought that the only way was to make an L-shaped buckle because I wanted to suture only in one point in a superotemporal quadrant. So I found a titanium stent, not in my OR, in the orthopedic neuro maxillofacial surgery. They had this very nice titanium stent that I placed in the silicone sponge, the 507 that I was using for retina detachment surgery. And I created the first model of buckle. And that's how it started. And I was so pleased with the result that I kept doing it all my life. And,
Brilliant.
in this special field, there's one more tip that I want to give to young colleagues. I think I have never observed more ostracism in our field as against the macular buckle. I mean, I've been giving the first talk on macular buckle, Flavio, in 2009. And since then,
Wow.
I'm giving, I'm changing the slides, but the results are the same. The macular buckle concept is the same. And every time at the end of the talk, I have so much criticism from my colleagues saying, it's not true. We can have brilliant result with vitrectomy. We don't need the macular buckle. The macular buckle is full of complication. Always, 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 always. And I'm going on with my life where I observe that this is not true because I always receive patients that have lost one eye because they were treated in the standard way with 5 or 6 surgeries, silicone oil in, silicone oil out, relapses. They don't see, they have glaucoma. They come for the other eye. I place a macular buckle and they are great for life. I still see them after 10 years. So what I want to tell my colleagues, my young colleagues, is that if you have an idea, if you have some strong ideas about something, just try your best to demonstrate with solid, undisputable data that your idea is true. So don't settle on dogma. Don't even settle on what other people tells you, because just focus on what you are sure of, publish, collect data, and move on with your idea. That's it. I have a colleague. Last year, I was interviewed by an Egyptian colleague who told me, but why in the world there is no session on macular buckle in the congresses, and everybody's telling you that they keep do the pars plana vitrectomy, and you keep saying that the macular buckle is the way to go. And so I told him, I don't care, because the truth is the truth and you cannot change it. And I thought about Galileus. I thought that in 1600 everybody were thinking that everybody were thinking that the earth was flat, but one person said that the world was round. He was, I mean, his end was not so happy, but because he was killed. But anyway, he was he was true. He was right? He was telling the truth,
Right.
and he was Italian. So I said, I will move on and I will demonstrate that this is the way to go.
And Barbara, how was the idea to develop the loading device? You developed together with the buckle, or it was probably after, I mean, because it's nice. It probably make easier for us to do it in.
8 point easier. So I was telling you that I tried to buckle the macula in any possible way. But what I realized in years that for almost 10 years, from 2007 to 2018, even more than 10 years, I used the L-shaped buckle with the titanium and sponge. And I realized that even if it was successful, colleagues were telling me, we don't do it because we don't have it, because it's an off-label model and we don't have it. We will not do what you're doing. So I decided to focus on making the surgical technique available and easier. And that's what happened. First of all, for a few years, I worked with a company trying to make my own buckle that could be, commercially available. But then it happened, I realized that it was too difficult because the regulations in Europe, like the FDA, the CE mark, is very, very difficult. It takes a long and expensive clinical trial to build an implantable device.
Mhm.
So I learned in those years that there was a company in Spain that they were already making a custom-made product. And so I thought maybe it is faster, smarter, and easier to go to them and work with them, and instead of starting from scratch. So that's what happened. I went to that company. I tried their buckle, but it was not easy. So I tried to modify their product, and that's what happened. I
Mhm.
modified their product, always with the idea to make it easy, in order to allow colleagues to use it anywhere in the world with a short training and easy step. And the loading device follows the same idea, is to allow the insertion of the buckle in a fluent, easier way. It keeps the buckle steady while you suture, and it helps you to check the position of the buckle at the end of surgery. That's it. So now actually I've just published the new technique, and it's very smooth. It's a
Yeah.
30 minutes technique that anyone can learn.
Yeah, watching the video seems
Yeah.
pretty easy. Not easy to do, but easier than the older videos we see on it. It's awesome. You did a great job. Yeah.
And this is what I was telling you. I learn by reviewing my data. In 2018, I said, I want to collect all the data from the patients that I operated, because I kept consulting them and reviewing them. So I asked my patient to bring me all the old OCT that they have. And in this way, I could see the natural history before the operation, the evolution of their disease, and then what happened after my operation.
Mhm.
And I learned so much that I had not realized while I was doing the surgery. First of all, I learned the real natural history of myopic traction maculopathy. And I understood that it was not a classification that I had to build, but something that described the evolution of the disease. It was a staging system, because MTM evolves from one stage to the next. It always changes. It is a dynamic disease. And second, I learned where the macular buckle was a good indication and in which cases it was not a good indication, in which cases we needed vitrectomy and in which cases vitrectomy was a mistake. And so it's been wonderful to learn from my own mistake, my own data. And that's how I came up with the MTM staging system and then the proposal of management.
Okay. We know. Does someone have a personal question for her?
Yeah.
No, I think I think so. It's great that that Barbara is is telling all these challenges. I was unaware that she was the one with Grazia that introduced the current technique for RB transplantation. Phenomenal. That's what we do here. When we have good cases, I have taught in fire surgical sessions to how to do your technique. And we I suffer a little bit from this challenges because we do a lot of endoscopic surgery, and there's very little surgeons that are experienced in vitreoretinal endoscopy. And so when you talk about it in the meetings, it's the same reaction that you get. I was witness this past Retina World Congress, a discussion that they were giving you some heat. And I was like, I was so ready to jump on the microphone to try to to defend you. But so I have the same similar experience. And, when we work on tough surgical cases,
Right.
it's easier to have criticism than to take the time to actually learn the technique. And I truly appreciate, yeah, and I really love the fact that you did the staging classification, because of the evolution, and in fact telling your critics that you guys are right in particular types of myopic traction maculopathy, but the macular buckle, it's great for these other stages.
The stages.
So it's it was a very kind way of you showing with data that we're both right, but I think you guys should learn this technique also, because these particular type of patients will benefit more from your macular buckle.
True. Exactly. Thank you so much to say that. And in fact, it was an effort to understand why my colleagues were sustaining the vitrectomy option only, and to basically try and learn this to try and clarify this discrepancy between what I was listening in the meeting and what was the real life. I keep receiving referrals of patients from all over Italy, and telling the truth, from all over the world. I operated patients from United States, from China last week. I operated a patient from Kuala Lumpur, because colleagues actually in real life, they send me the patient, and I think it's very, very honest. What I would like to happen is that you learn, so the patient don't have to travel, it's much easier now. Anyway, I
I
totally
was gonna
agree.
say, I think I'm
And,
gonna bring my team to go visit you in Italy.
yes, please come.
Yes.
And we will have a live course on MTM and macular buckle, because the rate of prevalence of this patient is increasing in the world. So we all need to master that technique as well.
Yeah.
You're working with AJL?
Yes,
Who-
I am working with
Yes.
AJL, and yes, we are about to.
Okay.
Yeah. Anyway, we will move on,
Yeah.
and I want to work with him in the future. Yes.
Barbara, do you know how many patients have you operated in macular buckle? And for how long have you been operating them?
So I operated the first in 2007, and I think between the one that I operated in Italy and abroad is more than 400. I place it in my slides, but and I have collected a huge amount of data on almost not all of them, because some of them I could not follow. I just finished the publication that I have submitted. Hopefully, it will be published on 250 eyes followed for 15 years.
Oh,
Oh wow.
For this type
That's
of
amazing.
pathology, there's nothing else published with this
Amazing.
type of data. I looked into that, but really
Wonderful.
the best thing is to still visiting the patient that I operated like 15 years ago, and realizing that it was a good thing to do. It doesn't always happen. We make so many mistakes. I always have my days where I'm so frustrated for patients and don't do well. I think, so when I visit the patient that do well after so many years, I try to build the strength to move on and say, okay, it's good. I still have to do vitreoretinal surgery, because sometimes I want to change and sell flowers or do something else because of the difficulty of what we do. But I realized that most of the time we do something good. So it makes sense to move on, even if we make so
And I
many
think
mistakes.
I think we're ready to move on actually to your presentation, so you can give us
All right.
to find our way into knowing the proper indications
Yes.
for the macular buckle and how to do them.
Yeah.
Is there a duration of my talk that I should respect?
No,
No.
you can talk more. Don't worry. You can talk more. So we know that you have an extensive experience over the last 30 years with topics such as autologous retinal transplantation, eye reconstruction after trauma, but today she will do a class for us about myopic traction maculopathy, just for introduce the other expectors.
Thank you for allowing me to present this talk on macular buckle to treat myopic traction maculopathy. I will present a very long-term study on a large case series. A few years ago, I have published the new myopic traction maculopathy staging system, which is summarized in this table. This table tells you everything you need to know on MTM, from stage 1, where you can observe the initial schisis in the inner or outer layers of the retina, to stage 2, outer schisis, to stage 3, a combination of schisis and detachment, to stage 4, where the retina is fully detached, there is no more schisis. For each of the 4 stages that describes what happens inside the macula, if you look now at the inner fovea, we can have stage A, where the fovea is intact, or stage B, where we have a lamellar macular hole, or stage C, where we have a full thickness macular hole. The table always also offers you information on the average visual acuity per each stage and on the time taken to evolve from one stage to the next, so you have a prognostic information for your patient. So in summary, how to define the stage? The stage is very easy. Just look at the macula and select 1, 2, 3, or 4. Then look at the inner fovea and select A, B, or C. Let's try it together. For example, in this case, you look at the macula, the layers inside the macula. You see there is an inner schisis. So this is stage 1. You look at the inner fovea, you see it is intact, so this is stage 1A. In this case, look at the layers of the macula. You see they are all detached from the RPE. Then you look at the inner fovea, it is intact, so this is stage 4A. In this case, the scan is taken with the wide field OCT, which better depicts the profile of these very long eyes, not just for the width, but for the depth. Sometimes in the standard scan, you only see one piece of retina, you don't know where the sclera is. With the wide field, instead, you see everything. The macula you see is completely detached, the fovea is intact, so this is still a case of MTM4A. In this other case, you can observe that in some spots the retina is detached, in some spots we have schisis, and in the inner fovea we have a lamellar macular hole. So this is stage 3B. In this case, there is a combination of schisis and foveal detachment, but the inner fovea is intact, so this is stage 3A. And the staging system was validated, but first of all, from a small group of colleagues, but then through the help of Retina World Congress, there was an international validation where 65 ophthalmologists from 10 countries, from all continents, they were not familiar with the staging system. The task asked to them was to recognize the stage of 20 OCT just after studying the table that I show. And the result was that there was a very high agreement. So basically, just to say that the staging system is easy to learn and easy to use. Let's move on to treatment. Should we treat or not to treat the MTM? And if yes, when and how? The question is not redundant because most of the time I realize that some patients with MTM are told that there's nothing to be done. But this is not true. We should treat MTM. And what does the literature report on the success of treatment for MTM? As you well know, the standard treatment at the moment for MTM is vitrectomy. So what the literature say about vitrectomy? This is one of among many papers that you can find reporting a 60% functional success and 80% anatomical success. It also says that foveal detachment and higher category, so more severe stages, are associated with functional and anatomical failure. And I can tell you that this is true. This is exactly what I observe in the real life, but this is not acceptable. We should understand that the staphyloma, so the ectasia of the posterior scleral wall, is not the same in every high myopic eye. There are many different types of deformation and protrusion in the eye wall. So basically, a staphyloma like this is not very deep, is very large. As you see in the MRI, reconstruction of the eye, it's a very large eye, but it doesn't have a deep staphyloma. So in a case like this, if you remove the vitreous, I'm pretty sure that vitrectomy can be efficient. But in a case like this, where you have a deep posterior staphyloma, would you do vitrectomy? What can you expect? Would you do vitrectomy in a case like this, where you have a very thin fovea? Would you heal something and make it even thinner to do what? To obtain what? Look at this wide field image. So just by looking intuitively at the image without knowing nothing on MTN, just use your intuition. What do you think that might happen if you push down the retina from the inside? However, some guy did vitrectomy and gas because it is the standard technique that everybody do, and this is the result. Is this a success? Well, for most colleagues, this is a success because the retina is indeed attached. But the macula is atrophic, there is a full thickness macular hole, and vision is very poor. So I think this is not acceptable. These are only some of my publications on the topic. I would like you to focus on this one, which is proposal of management this time of MTM, but customized or based on each stage. So this is the same table enriched in red with guidelines, at least proposal of guidelines of management customized per each stage. In summary, what I propose is to treat the full thickness macular hole from the inside with an ILM flap or whatever we have if the ILM is not there anyway, in endo-bulbar maneuvers, while to treat the schisis and detachment by pushing the staphyloma with the macular buckle. Indeed, it is important to create a flap to close a macular hole, but you can see from the view on your left through the microscope, it is very difficult to see these holes. There is low contrast. You don't see almost anything, not even the hole. The intraoperative OCT is very useful in cases like this, but it's not widely available. But if you have to treat schisis and detachment, you need a buckle. So in summary, if the problem is the retina, treat the retina, like for the holes. But if the problem is the staphyloma, treat the staphyloma. It's simple as that. I have started many years ago with different prototypes, sponges, bands, even a pediatric Foley balloon. And in 2007, I proposed this first model of L-shaped buckle because all the previous models were actually working. If you buckle the macula, you solve the problem. But there was the need to develop an easier buckle that could be widely used. Yeah, I modified the buckle by making the lateral arm smaller and introducing the light for transillumination a few years later. And then in 2020, I started to work with this company that was already making this buckle because the previous one was off-label, so nobody was using it. Instead, this buckle was commercially available as a custom product. I didn't really like the buckle because it was not so easy to manage, so I modified the buckle in 2022, and I'm actually proposing new modification, but now I like it even better, and who knows, it will be improved further with the time. But I think this already a very good product that everyone can start using with satisfaction. It has a head, which is the buckling side, and the lateral arm has 4 holes to lodge the suture. This is the external part that has a spot to place the fiber optic for transillumination. This is a loading device that can be connected to the macular buckle. It helps to insert the buckle, to hold the buckle during suturing, and to check the position of the buckle by moving the loading device at the end of surgery. So here you see the two connected with the fiber optic for transillumination. In summary, the technique is a 30 minutes procedure that can be done in sedation and local anesthesia. You have to open the conjunctiva and tenon from inferotemporal to suprarenasal. Then you have to isolate the temporal and superior lateral muscle. You mark the limbus in the middle of the quadrant. It is the supratemporal quadrant. And from that point, you mark where you want to place the suture. This is called distance limbus needle. Then you pass the suture. You prepare the macular buckle with the light, if you like. It's not mandatory, but it is helpful. you connect it with the loading device, and then you insert the buckle with your pushing the buckle into the superotemporal quadrant. You pass the suture through the hole, and you have to tighten the suture very well so it stays exactly where you place the marking. And then it is extremely important to check the position through a flat corneal lens. You can also use the panoramic viewing system, but in that case, you need to place you need to place a light, and I encourage you to avoid opening the eye. Don't do paracentesis, don't do sclerotomies, because it is a mistake to change and lower the intraocular pressure. I used to do it, I used to advise it, but I learned that it is much safer to avoid this step. This is the insertion of the buckle from a different point of view. You basically see you have to move the eye nasally and insert the buckle in the superotemporal quadrant, and that's it. It's done. So in a preliminary study, I wanted to build a nomogram to study the correlation between the axial length of the eye and the distance from the limbus where to place the suture. There is actually a nice correlation with the increasing axial length, the spot to place the suture, it is at a longer distance. But the final aim of this study was to offer a customized buckle of different sizes, short, medium, and long, in order to be able to suture always around 12 millimeters from the limbus. This is very convenient because 12 millimeters is easy to approach. Let's say if you try to place the suture at a longer distance, let's say in the range of 15 to 18 millimeters from the limbus, it is very, very difficult. And if you place it too close to the limbus, you risk extrusion of the buckle in the following months. So 12 millimeters is a very safe area, but of course you need a different size of macular buckle, whether you have a short eye or a long eye. These eyes are all long, but they are they range between 26.5 to up to 38 millimeters, I think is the longest eye that I have operated. In my personal case series from 2008 up to now, I think I've operated more than 400 buckles, but I have available data on 250, and 55 of them were made with the last model that I have presented. The average axial length is 32.2. Most of them are female. As we all know, this is a female pathology mostly. Sorry for the mistake. The mean age was 63 years of age. So in 2020, after publishing the MTM staging system and the proposed guidelines for management, I changed slightly the procedure. First of all, I stopped doing vitrectomy for stages A and B. So I did the vitrectomy only in the full thickness macular hole, and I stopped doing macular buckle for stage 1. This was the publication. So my results were the same throughout the series from the beginning to the end, very, very high anatomical success rate. So this is not a fake number. If you place a buckle under the macula, there is basically no way that you cannot reach the results. It's impossible. You always reattach the retina. It must be well centered. So if the buckle is decentered, it doesn't work. But if it is centered, it will reattach inevitably the macula. What about function? So vision improves in average 3 lines, which is very good. Let me go back, sorry. At least 40% of patients have a final vision of 20/40. This is very important to say because most colleagues think that these are low vision patients that don't improve their vision. But that's not true. If they don't have atrophy in the macula, their final vision can be extremely high. So what about complication? This is the change between and after following the guidelines, the rate and type of complication. So elevation deficit and diplopia you can have. It is not a big diplopia, and most of the time it resolves spontaneously after 1 year, but you might have it. Extrusion still is possible, and it also depends on where you have placed the suture. Choroidal hemorrhage in 0.5% and iatrogenic full thickness macular hole were the sight-threatening complication. And you see that after the year 2020, I basically stopped seeing them. Why? Because I stopped doing vitrectomy in stages A and B. So I haven't had any more iatrogenic full thickness macular hole that are induced by touching the ILM or just by removing the vitreous. Also, I stopped doing paracentesis or sclerotomies, therefore no more significant choroidals. Let's see some example of pre and post-op. On top, you see the pre-op, stage 3C. Vision is 2200. I did buccal vitrectomy, flap, ILM flap and gas, and this is after a few years. 2030 is the final vision. There is no scotoma in microperimetry. The retina is flat and the hole is closed. This is a pre-op, and this is the post-op 3 years later. Pre-op, please try to imagine what might happen to this eye if you do vitrectomy. The normal story of an eye like this is vitrectomy gas, the retina attaches. Then the gas goes away, you have a relapse. Then vitrectomy and silicone oil, then the oil is removed, the retina detaches again. Then heavy silicone oil might be used based on the country. And then the eye finishes with the retina attached, the hole open, and glaucoma, no vision. Instead, this is the result with vitrectomy, macular buckle, ILM flap, and only gas. This is an example of an eye operated multiple times with the same story: gas, light oil removal, heavy oil, no vision, glaucoma. The patient comes for the second eye. Apparently there's nothing wrong, but vision is low because of this OCT. This is a disease that can be seen only with OCT. If you look through the fundus, very rarely you can see it. You need the OCT, and if you have wide field, even better. So you see a stage 3A. The retina is detached. There is still some schisis, but it is detached. And there is an interesting vitreoretinal traction, but not on the macula. It is extramacular. So I applied only the buckle, and 2 years later, the retina is fully attached with very good vision. And if you look at the OCT, there is still the original traction, but relieved because the tension is relieved when you shorten the eye. So this is just another example. And this is to show you how the eye looks after macular buckle and after multiple vitrectomies. Most colleagues ask me how the eye looks after a macular buckle. It looks perfectly normal. Instead, the eye with the multiple surgeries, glaucoma drops, looks as you can see in the picture on your right. So most colleagues would do maybe vitrectomy and foveal sparing in a case like this. She came back after some times with a further loss in vision and visual field. This is the color picture and the autofluorescence, and this is the wide field OCT. She evolved from stage 3A to 4C. You can see it in this scan that there is a full thickness macular hole. So how can you imagine to reattach the retina and close the hole just with vitrectomy? There's no way with a staphyloma so narrow and so deep. Instead, you see here, if you apply a macular buckle to treat the staphyloma and you go inside to close the hole, you can reach this result after 1 month that lasts for years, she has still a very good vision. This is interesting because the same patient had a different story in right eye and left eye. So he started with the same stage, the 3A. He received a macular buckle in one eye and vitrectomy, no ILM touch, just vitrectomy in the other eye. So you see the difference here. In the macular buckle only, the retina is attached. In the vitrectomy case, the retina is fully detached with a iatrogenic macular hole. So then I treated the second eye as well with a combined surgery, and the retina could be fixed. This was very interesting. It was a case-case match. What about atrophy after macular buckle? Some colleagues are sustaining that macular buckle induced choroidal atrophy. Here, from A to E is the same eye followed for many years. This is published by Kyoko Ono Matsui. This is the natural history of atrophy in high myopia. She studied many eyes for 18 years, and she found that 60% of these eyes has a very severe progression of atrophy without touching the eye. This is the natural history of atrophy in this eye. So what did I do? I made a study, observational comparative study, to find out whether the macular buckle was inducing more atrophy than the natural history. I asked two independent colleagues, not me, to evaluate the cases. And so we evaluated the incidence and rate of myopic atrophy and CNV in eyes operated with macular buckle and in the contralateral eye. So basically, they follow the groups of operated eye for collecting images over a very long time, images of color fundus, autofluorescence, microperimetry, visual acuity, OCT. Following the same judgment of atrophy suggested by Kyoko Ono Matsui. They collected 116 eyes, 70 operated with macular buckle and 46 as control. It was the contralateral eye. And notice that the baseline atrophy were more severe in the operated eye. So it turned out that basically there was no eyes presented a macular buckle induced atrophy. This was very important. You see here some example. One patient followed for 10 years on the left, the macular buckle eye, and on the right, a vitrectomy eye, the contralateral eye. And you see there is no development of atrophy. Maybe there is a suspect here in the vitrectomy eye. This is another example of a patient followed for 7 years only with macular buckle. There is no atrophy induced. I just published this study. And I want to show you my best case just to give you hope for the vision improvement, because most of colleagues think that these are atrophic eyes. This is a 54-year-old male. Vision preoperatively is 2200, axial length is 32.8, 21 diopters of myopia. The OCT shows a detachment of the macula in stage 3A. So I did the macular buckle, and you see the result in OCT 3 years later. Then I did phaco. I implanted the multifocal IOL, and the vision is 20/20, far and near uncorrected. This is my only eye like this, but I think it gives a lot of hope. You see here different results. This is how the buckle appears in magnetic resonance. So I use magnetic resonance to study the shape of the eye in the orbit and the relationship with the optic nerve. You don't touch the optic nerve if you don't want to. So I would like to encourage you to try this technique, to try the guidelines and experience if you can compare your result with mine and reach good result in this difficult disease. Thank you.
Outstanding.
Thank you
That's
so much.
wow. So I have a couple questions because I've done a few of the T shape,
All right.
and it was very hard to do. And one of the things that I encountered was in one of the patients, the um, the buckle was actually sliding on the posterior staphyloma. So
Ah,
as I was
you
suturing,
could not fix it in one position.
it
Yeah.
was, yeah, it was like, I was putting the light, I was seeing that the light was going up. And so
Yeah.
I like your modification because now it's a wider
True.
paint, not only the teeth.
Yeah.
It'll be less likely to do what happened to me. And after this case, I stopped doing it because I said
Ah,
it was like it
yeah.
was a nightmare.
Yes.
And we have in Canada, we have a very hard time to import. We don't have AJL in
I
Canada, and
see.
so we have to do personal importation for
I
each
see. I
patient.
see.
So it was taking like at least 8 months.
I see.
That is a hurdle that in North America we still and I believe in Brazil same.
I
It's
see.
the hurdle of access to it.
True. True.
So
I hope this problem will be solved. And actually, as you mentioned, we are always speaking about C shape, L shape, but it's amazing how much difference each detail makes. I've always done this shape, and initially it was the titanium with the silicone, but the size, the width, the length, having or not having the holes, how it is the support anteriorly, how it is the shape of the head. I'm still changing because, for example, I started with a hemispheric shape, which was the shape of the AJL model. But then I didn't want to have a convex shape at the end. So now I'm making a flat top. And what about the height? 4 millimeter, 5 millimeter, in some eyes is too much. So I'm still studying the shape. But I actually, as you said, I learned that if the lateral arm is too small, then the buckle tilts. And so you don't have enough steadiness and resistance in the, instead, I enlarged the arm and it was, you place it in one place and it stays there. Do you know why I enlarged? I actually did not enlarge for that reason. I enlarged it because sometimes it is rare, but you need to remove the macular buckle. For example, if you have anterior erosion. So what was happening is that if the arm was very slim and the head was large, when it's the time to remove it, there is a fibrotic capsule all around, and you cannot remove the head because it's larger than the anterior capsule. So I said, if I make the arm as large as the head, when I remove it, it will be much easier. It turned out that it was even more steady when I placed it. So anyway, it's a work in progress, although now I'm very happy with the result. I hope we will have the CE mark and all the registration approval in different countries, so it will be easier to access.
And for this placing the suture, it's only one suture in each side. There's not like a deeper suture anymore.
There are in this model, I placed four spots, two anterior and two posterior.
Okay, there's still a posterior.
Telling the truth, I always place the anterior, and I observe it's more than enough. But in some very deep staphylomas, if you want a stronger indentation, you can use the posterior one, and as leverage, it will do like this.
Okay.
So just
so you try first only the anterior ones, and
only
the two
anterior
anterior
one is enough. Yes.
Yeah, because the posterior ones were pretty tough to pass the suture to.
No, I
And
know, but that's why I asked the company. We cannot make it has to be with different sizes, short, medium, and long, in order to always suture at 12. 12 is the perfect spot to place the suture.
Great.
And Bárbara, which case you suggest to start the training, or which case you have to avoid in the beginning of the training with this technique,
So at the beginning of the training, I suggest you maybe you can encounter detachment in cases that have already some atrophy at the posterior pole. And even with a full thickness macular hole. In those cases, you can place the buckle because you're still working in the low vision range, so the expectations are not so high. And without doing vitrectomy, because vitrectomy is the hardest part. If you have a high detachment with a full thickness hole, you just place the buckle and inject the bubble of gas. Ask the patient to face down, the retina will reattach, okay? Of course, you will have a full thickness macular hole on a flat retina, but if the macula is atrophic, you don't care about closing the hole because vision will not change. So I think this is the best way to start. But if you master the technique, you will learn that with the patients that don't have atrophy, the expectation in vision is very, very high.
And when you
And don't place the buckle if you have only inner schisis. In stage one, it is a mistake to place the buckle, because if you don't have detachment or wide schisis, you will induce a schisis in the fovea if you push it too high. It happened to me because at the beginning I was so excited that I was placing buckles in any high myopic eye. And then when I made the review, I said, oh my God, what did I do? I induced a schisis in the fovea because I was pushing a fovea, which was basically normal. So don't do it. Wait for the schisis and detachment.
when you combine with vitrectomy, what is the sequence of
So
buckling?
you can do either combined. Let's say my preferred technique is to place the buckle, attach the retina, and then if you have to close the hole, you do it later. Okay, because it's easier to deal just with the full thickness macular hole in stage 1C than 4C. But sometimes you have to do combined for many different reasons. And so you place the buckle and then you go inside. So it's easier to do all the maneuvers to close the hole.
All right.
And when you just do the macular buckling, you always put gas.
I do.
and face it out.
I don't use silicone oil. Try with all your energy to avoid oil in these eyes, because very often you end up in trouble.
Right.
So, but any preference about SF6 or C3F8?
I only use SF6 in my OR since 15 years. I don't have other gases for any other reason. Just a few days are more than enough.
So you do like a pneumatic, right? So you put the
Like a
buckle, and you
pneumatic.
inject the pneumatic.
Right. But I do it only if there is a full thickness hole. If you don't have a hole, no need to
Just
inject
buckle.
anything. Just buckle and wait. It does not resolve immediately. It takes weeks and months, but then it will be resolved.
So the pneumatic is reserved for stage 4.
Stage 4. No,
Okay.
no. Stage C.
Stage C. Yes, the macular hole.
Thickness.
When you have full
If you
thickness.
have a stage 4A or 4B, you don't need to inject anything. Just place the buckle.
Just place the
Stage C, better to use also the bubble. I don't know, maybe air is enough. I don't know. I haven't tried, but I mean, a few days is enough. Okay. Right.
And where can we buy the device?
So I think at the moment, the best way is that I put you in contact with AJL, or you can try yourself and ask if they have a distributor to provide you the buckle. Okay.
Is there already available the different sizes, the small, medium, and large?
Yes, they can make it as you like. You just give the axial length. If for the first, if you want to send the OCT to me, I'm available anytime to guide you for the first trials.
And the name of the implant is a Parolini device?
It's actually NPB, which stands for New Parolini Buckle, but I mean, it's NPB. After so many years, I accepted to have indirectly a name on it.
Barbara, we're gonna let you go.
Thank you
It,
so much.
it was a true honor. This was like a master class of
Thank-
myopic traction maculopathy and macular buckles. Truly appreciate the time.
Thank you. I've been waiting for the pre and post op of your patient.
Oh,
Thanks.
Thank you so much.
Bye-bye.
So, unfortunately, our time is running out. I'd like to say a special thank you to you, Dr. Parolini.
Thanks.
Thank you for staying with us today. Thank you, Dr. Flávio Rezende. Thank you, my friends and colleagues. And a big thank you to you, our listener, for joining us today. We hope you found this episode interesting and informative. And if you have some friends that also like retina, please share with them. And see you in the next episode. Bye.
Thank you.
Bye.
Bye.
Thank you. Bye bye, Barbara.
Thank you, Flavio. Bye.
Thanks.
Thank
guys.
you all.